I'm board certified in anesthesia and double board certified in pain, and I've been in practice for 35 years. So I've seen one or two problems in my career here. And I've been in Western North Carolina for the last 17 years. Our practice has now, I believe, 11 locations throughout Western North Carolina. We've really grown. And we're happy to do that and serve the community here, mostly a rural community, but we're enjoying a lot our practice situation that we have in seeing patients. So we're going to talk today about pain management. We're going to talk about really what that is. We're gonna rest some misguided assumptions about what it may be, and let me talk about what it really is and what really we can do with pain management and what the aspects are that can really help your problems without taking any assumptions about it. We'll learn about chronic pain treatment options. We'll learn about see what options may work best for your personal chronic pain, because every pain condition is different, and not every pain condition can be treated with the same treatment, and not every patient with the same condition can get treated with the same treatment plan. It has to be modified to just fit your plan for your particular problem. We'll suggest things for you to discuss at your next appointment. So this discussion is going to raise a whole lot of questions and that you may have. We'll try to answer some at the end of the video. And so it's best to sit down and talk one-on-one with your specialist about your particular problem to get the best answers. And we're very good at that, very good at helping people understand. Let's see if I can. Lee, if you're there, I'm trying to figure out how to change or scroll screens.
Hit the enter.
Yeah, enter. Not working.
All right, how about the down arrow button?
Not working.
Okay.
Video settings, participants, Q&A. Let's see. Audio support. Pause. New share. Well.
Let me run mine.
Oh.
There you go.
I fixed it. Very good. All right. The first important thing to understand are the different types of pain. And we divide pain into various categories, but more commonly, we want to understand if a pain is a mechanical pain problem, such as, well, say arthritis in a joint with a worn out joint, or neuropathic pain. Classic example, diabetic neuropathy. Diabetic neuropathy occurs with burning type pain in the feet. It's really not mechanical in nature. It's a damage to the nerves themselves. Neuropathic pain can occur without trigger, which means a mechanical pain occurs when, something hurts and you may press on it, or my knee hurts when I walk on it. That's a trigger to cause the pain. Neuropathic pain can just spontaneously occur and be unremitting, and it doesn't require anything to trigger it. Weakness can be involved, as of course the nervous system is involved that's being damaged. You can experience weakness. You can experience numbness associated with neuropathic pain. And it's usually described as a sharp, burning, stabbing, kind of pins and needles sensation, more than an aching and pressure type pain, which is more classic for mechanical pain. So does chronic pain prevent you from enjoying? Ask yourself these questions. Chronic pain is a miserable experience, but it affects a lot of things, and most importantly, functionality. So are you able to perform these basic tasks around the house? If your pain is limiting you, then that's a significant pain problem. Is it affecting your ability to work and be productive? Many patients have just quit working, lost their jobs because their pain is too severe. Playing with children or grandchildren, it's a passion of our older patients. And they'll complain to me commonly, I just want to be able to play with my grandkids and I can't do it. I can't lift them up or play because it hurts too much. Outdoor activities such as walking or hiking. I have a lot of patients that have moved here just for that reason. They want to retire and they want to go hiking in the hills and they simply can't do it. And they're very upset and depressed. And that's the main reason they came out here, to enjoy the great outdoors of Western North Carolina. Are your activities such as gardening and arts and crafts, are they affected too? I have many patients that quit gardening for years because they just couldn't tolerate it. But that's their passion. They want to have that restored to them. And sexual activity can be altered, although patients don't talk about that often. Sometimes they will, and that significantly affects lifestyle. So these can really be not only miserable experiences, but affect lifestyle from a functionality standpoint that just becomes really intolerable. Uh-oh. Let's talk about chronic pain treatments and the tier of how we approach patients for chronic pain, how we treat them. The primary thing to do is to try to come up with a diagnosis, as we can see on the left at number 1 there, it's in orange. Chronic pain is not a diagnosis. Pain is simply an experience. A diagnosis for pain would be herniated disc, arthritis, neuralgia, post-herpetic neuralgia. These are diagnoses. And in order to treat chronic pain effectively, we have to make the best diagnosis possible. That's critical. So when we evaluate somebody, we'll get a thorough history about the pain issue, take a complete examination or very focused on the pain areas, try to gather old information, medical records, x-rays, MRIs, whatever we can to try to support giving us information to try to make that diagnosis. And once we do, and we have the best diagnosis possible, the treatment plan seems to be narrowed down and work better. So that's very important. We start with first line or first tier pain therapies, which are basically very, very modest. So they may be anti-inflammatory medications, a TENS unit, which is a superficial stimulating device. It's a box that has wires that come off, that little pads that stick to pain areas and induce a tingling sensation with electricity that can block pain. Very benign thing to do. We have a psychologist that sees patients, and there's a lot of patients that have comorbid, we call comorbid or combining psychological issues. For instance, post-traumatic stress disorder is a significant one. We see patients coming back from war, patients that have had severe accidents, loss of somebody, and it's very hard for them to manage and control their pain based on this stress disorder that they have. Our psychologists are extremely helpful. Talk about nerve blocks. We'll talk more about nerve blocks and what their utility is. Mostly diagnostic, but they're very simple and very easy to do. A nerve block is the thing the dentist does when you're going to get a cavity filled in your tooth. He does a nerve block in your mouth, whole lip goes to sleep. You can't feel a thing there. When you touch it, you're totally numb, but he can drill on any tooth and you have no pain. So that's an example, classic example of a nerve block. There's many nerve block techniques that can be beneficial, both diagnostically and therapeutically. So when we pass that, we get to second tier therapies. And second tier therapies include stronger medications, such as opioid medications, neurolysis, which is the destruction of nerves. Let's just say in some cases we'll block a nerve, and that nerve block takes away the pain, yet temporarily, because it's going to wear off. Sometimes we can go back and destroy that nerve with a radiofrequency ablation technique, such as displayed here, and get long-term relief. In fact, I have this done to my back for my arthritis, and I've had it done twice, and I've responded very well. So I can tell you firsthand how well it can work if you have the right diagnosis. When those second-tier pain therapies fail, then we go to more advanced pain therapies. And these are ones that less pain specialists do because it is a very advanced technique. Most of the ones that we do are either going to be neuromodulation or implanted surgical pumps and surgical intervention. Surgical interventions such as I have a herniated disc and I need a back operation to remove that disc. That's a surgical therapy to try to relieve pain, albeit done by a surgeon. That's what they're trying to achieve. In pain management, we're the ones that do neuromodulation techniques, which are otherwise known as spinal cord stimulators, and implantable drug devices. You may have heard of pain pumps. They may be called morphine pumps. These are administration of medications, mostly opioid medicines, mostly morphine, directly into the spinal fluid in a pump that's implanted under the skin that infuses the medication straight there and goes to the spinal cord to block pain, which can be extremely effective. But these are the most advanced and usually reserved for the end stage patient that's not getting any benefit from the first, second, or third tier therapies. Physical therapy. Well, let me back up a little bit and talk about the 4 modalities in pain management. 4 modalities. Using the 4 modalities in conjunction with each other is shown to be the most effective and even supported in the medical literature. And those are physical, medical, interventional and psychological. So we'll talk about the physical aspects of the physical modalities, physical therapy, and we'll lump acupuncture, chiropractic care, relaxation techniques. These are all lumped into part of the physical therapy component of pain, or physical medicine part of pain, that are very effective too. And we use these commonly in various patients for various diagnoses to try to achieve relief. Anti-inflammatory drugs are used at the baseline, level 1. Adjuvant medications is talking about medication management. Now we went to medication management. An adjuvant medicine is a medicine that is not directly a medicine indicated for pain relief. It may be indicated for seizures or depression, but you can use these anti-seizure medicines or antidepressant medications, which affect neurotransmitters in the body, in the central nervous system, and they can make pain better. I just now spoke to a patient that was my last patient to say that had painful diabetic neuropathy. The first line treatment is an antidepressant, duloxetine. That's where you go first, typically, to treat that pain problem, not to opioids or nerve blocks. And I explained why to the patient. So they can be extremely effective. And of course, we try to use those when we can too. We talked about TENS units, transcutaneous electrical nerve stimulation. They can be effective. The nice thing about TENS units is that they're inexpensive, easy to use, and totally safe. So for that reason, they may be commonly used. Not that effective in a lot of cases, but they can be. And because they're so safe, easy, and cost effective, we'll try those. Then injection therapies. Most injection therapies that you'll hear about are injection of an anesthetic and or steroid and an anti-inflammatory. Really, that's going to be a steroid into a pain area. Excuse me. One of the most common ones to do is the epidural steroid injection. This by far is the most common injection interventional therapy to treat chronic pain. And it's simply a steroid injection into the spinal canal, into the epidural space, to treat pain such as from failed back surgery where there's a nerve root involvement causing leg pain, or a herniated disc that's pinching a nerve causing leg pain, something like that. The pain relief of these things varies in length and time, and there are possible risks, because now we're putting a needle into the spinal canal, and there can be some risks, but it is by far extremely safe and efficacious, and it's proven to be safe. And more of these will be done for interventional treatments than probably anything else that we do. So it's a very common technique, not always indicated for every single problem, though. Long-term opioids. And it's always been controversy, and this is the biggest controversy in pain medicine. Everyone's heard about the opioid epidemic that we're trying to fight. Basically, what that says is that we've seen an extreme increase in prescribing opioids to patients over the years. And unfortunately, there's been a significant increase then of complications of seeing people that become addicted, or those that have accidental or inadvertent overdoses. And that's not many, but we need to be cautious about putting people at risk to have those things by conscientious use of opioids. So in our practice, we do opioid management. But again, we're very conscientious, we're very safe about it, we're very controlled about it, so we can monitor patients correctly. And we're always going to try some sort of adjunctive therapy, and not simply relying only on opioids, but on all the other modalities to try to reduce pain. And that's with any patient, no matter what the problem is, no matter what the modality is we pick. Neurolysis is applying some sort of agent, either heat or freezing, or a chemical to a nerve that causes temporary degeneration of the nerves. What it does basically is these things damage the nerves. You can't do this to all nerves, but you can do it to select ones, and we know which ones those are. Usually they're the smaller nerves that go to a pain source, so we can damage it so that it's dysfunctional and not transmitting pain for an extended period of time. We'll take me for an example. I've had this rhizotomy, which is a nerve destruction technique to my joints in my spine, twice. First time it lasted 6 months. That's the average, so that was expected. The second time it's been 4 years. That's very rare, but it can extend that far to give pain relief. Usually we'd expect the nerve to regenerate and have to repeat the procedure. But we always just do the procedure and try to get expected results and then see what the patient needs in the future. And some patients have come back to me years later for a second treatment. Some have come back more early, but it can be repeated indefinitely in order to keep somebody out of pain. And for some diagnoses, that may be the only thing that we can do. It is usually reversible in that the nerve will regenerate itself, So no matter what the outcome is, the nerve usually does regenerate given time, and it'll go back to normal. And if it's the pain returning, we just simply repeat the procedure. And it's a radio frequency ablation, or RFA. You're going to hear this called radio frequency ablation. You're going to hear it called rhizotomy. There's different names for it, but they mean the exact same thing. Again, application of heat to a small area of nerve tissue so the nerves no longer function. You can freeze those, you can put chemicals on those, and you can actually cut those too surgically. That's usually not commonly done because that can create more neuropathic pain to permanently cut the nerve. So we don't do that so much. Commonly, it's going to be heating the nerve because that's the easiest and most discreet thing to do that causes the less complications. It's minimally invasive, so we do this on an outpatient basis, sometimes just with local anesthesia, but sometimes we use sedation. The procedures often takes no more than 10 to 15 minutes in our procedure suite in the office, and patients are immediately ambulatory and walking home virtually with every case. We consider using it if medications and simple steroid injections or nerve blocks have failed to control the pain adequately. In other words, that those are the lower tier things to use. When they fail, we go to the upper tier, and nerve ablations may be very effective. Typically, we'll do a nerve block first of the nerve that we think we want to ablate to see if it will stop the pain. And if it does effectively, although short course, we think it's meritorious then to go in and burn and destroy the nerve. It's actually required to do this by all insurance companies before we go doing an RFA procedure. Physician can perform a simple test called the diagnostic block, as I just mentioned, to see if it will be effective. Here you can see in the lower screen in the middle an example of a spine model. You can see these blue and red nerves coming out there and a probe going in, heading towards the nerve. So we use X-ray to guide us to see where these nerves are. Although we can't see nerves, we can see bony anatomy. We know where those nerves run, and that's how we can target specifically which nerve that we want to try the ablation on. The procedure is repeated, as I mentioned before, when the nerves regenerate, depending on how much time it is that it did regenerate. We talked about all the tiers. We talked about second tier. Now we're going to talk about the more advanced pain therapies. Those are implanted drug pumps and surgical intervention. I don't know that I didn't pass up spinal cord stimulation. Implanted drug pumps, they're very popular early on. They become less popular because they're one of the hardest things for us to manage with patients, and they do have higher risk than some of the other things that we do. I do put in pumps, and I have since 1989, so I put in quite a few. But again, it's patient selection that determines that the effectiveness is going to be more than anything else. It delivers medication, typically an opioid, and morphine is the prototype that we usually try to start with that goes directly to the pain pathways. Pain pathways and receptors for opioids are known to be in the brain, of course, and this is where pain relief can be affected, but there can be other effects in the brain, as we well know. But there are also these receptors that are all along the spinal cord. And we believe that sometimes using opioids that bind to these receptors in the spinal cord can be far more effective at relieving pain than systemically getting to the brain. And in fact, the doses of morphine that we use in the spinal fluid may be as low as 0.5 milligram a day or 1/4 milligram a day that can deliver profound effects, which taken orally and systemically, you'd never even notice. The side effects may be the same as oral medications, so it has to be limited by the side effects. It is reversible, which means if for some reason we don't want to continue this therapy, we simply taper the pump, stop the medication, and remove the pump if we need to. And it never changes any part of the anatomy of the body. It's totally reversible. It's usually reserved when all conservative treatments fail, and I mean all conservative treatments. So this is the last kind of ditch thing that we do for patients. More commonly, they're done for cancer patients, terminal cancer patients, because they can be extremely effective. But we do more for benign pain patients than we do cancer patients because we see those patients. And usually they have some pretty significant pain issue that just can't be relieved with anything more commonly. And oral medication is simply not going to be quite enough for them, or they're having too many side effects or problems with those. The risks are this is a surgical procedure. So it's a surgically implanted pump with a needle that goes into the spine through the dural sac into the spinal fluid to put a catheter in there. In the hands of a trained surgeon, it's still very safe to do, but it does carry possible risks, more so than a simple lower tiered procedure might. So we really want to consider carefully everything else that we've done for a patient before we go into something like an intrathecal pump. You want more information about that? Then your pain specialist can sit down and make an appointment with you and to discuss all that as maybe an option and what the risk may be. Surgical intervention is intended to correct an underlying problem. So take spine problems, for instance. Usually surgeons go in there to anatomically correct a problem. There's a disc herniated, they take it out. There's a bone that's unstable, they fuse it to make it stable again, something like that. So they treat structural problems with anatomic changes surgically. It ranges from minor procedures to spinal procedures that are very extensive, that can go on for hours. And the recovery usually is very tough for a lot of those patients. So even that should be considered as one of the last line things to do when everything else has failed. A repeat surgery may bring little or no relief, and plenty of studies have shown that successive spine surgeries done one after another usually bring less and less chances of relief. That's not always the case, but that's more or less the rule rather than the exception. So we see some patients with multiple spine surgeries that simply just keep getting worse with every one. And then again, that's not all patients, but at a certain point, the practitioners and the physicians taking care of patients say that's enough. We just really can't get this better. Turned over to us. We sometimes start with the more aggressive therapies because oftentimes the more lower tiered things have already been exhausted. So we may go straight to something high tiered. Possible risk and complications or side effects. Of course, with spine surgery and changing the anatomy, this is the higher chance of more risks occurring and more complications occurring and more side effects. So it's for this reason that things like advanced surgery should be considered really the last option more than the first or second option for patients. Let's talk about two other options that we do in our clinic. We're doing new and innovative therapies that we're learning. It's amazing how fast these new innovative therapies are coming out and that I'm going to get trained on and learn how to do. And I teach most of these things now. So they can be extremely beneficial. And we're impressed with some of the things that we can do now we couldn't do even 5 or 10 years ago. Excuse me. One of them is indirect decompression, and the other is spinal cord stimulation. And then we'll explain a little bit more about that. Indirect decompression is usually used to treat, well, for all practical purposes, something compressing a nerve. So patients with spinal stenosis, which is a condition in which tissue gathers inside the spinal canal, insidiously growing to squeeze the spinal canal narrower and narrower until it finally starts to squeeze on nerves. Needs to be removed or decompressed means it basically tries to eliminate the compression on the nerves. So you can directly do this by a surgical procedure, removing some of this bone tissue that you see on this spine model here, where this purple device is. That's a very aggressive procedure, sometimes creating instability in the spine, requiring a fusion, very large operation, long time to recover. Some patients respond if you'll just simply place the segmented level of stenosis in a flex position. In other words, some patients that have stenosis will feel better if they sit down. Their back pain gets better, their leg pain gets better. And as soon as they stand up, their back pain starts again, their leg pain starts again, and it gets heavy, and they're limited to how far they can walk until they sit down. That may be describing some of you listening today. This device you see here, this metal device with the purple paddles there, is a device that we implant in between the spinal bones, these processes on the spinal bones that stick out of the back, with patients that are kind of laying on an operating table in a flex position. So we'll implant this, and when they stand up, that level can't compress. They can't go back together, which pushes the ligaments forward into the spine and start to compress the nerves. So patients that sit forward, stretch that ligament and pull it back. This basically puts a patient on the operating table, stretches the ligament, then it puts that in to hold that position apart or in flexion so that that segment doesn't press on the nerves. It can be extremely effective in relieving some patients' pain with spinal stenosis. It's a minimally invasive procedure. Its complication rate is almost zero, not completely, but almost. It takes only 15 to 20 minutes to put this in under local anesthesia with sedation oftentimes. And patients almost always are walking out of the hospital within 1 hour with no other problems or symptoms. So it's a phenomenal procedure, and we do quite a lot of these. Here's an example of patients that have this problem. They have pain walking or standing. Some patients will say, my sciatica pain was so severe I couldn't walk more than 100 feet without having to sit down. The pain meds stopped working. Nothing seemed to work. Now I just stay home and I don't go out and do anything, because getting out and doing anything makes the pain so bad they can't go far. I can't get way around the store. I have many patients that come to see me. They last 5 minutes in the grocery store. They just got to get one item or two and get out. I tried medication, but it made me unable to concentrate. Some people have side effects of medications. The medications, by the way, can help with pain, but when you have nerves that are being compressed, it doesn't do much for that. So they're still going to get these same symptoms, including leg weakness from the nerve compression, and pain medicine isn't going to stop that. So here's an example on the right side of somebody pushing a shopping cart. If you walk around the store and seeing mostly elderly patients that are walking and really leaning on their shopping cart, not just pushing it along, but really almost have their arms down on top of the handle when they're pushing. They're trying to flex that spine forward to get pressure off the nerves. That's called the shopping cart sign. And it's very classic for patients that have stenosis. Patients are usually found in sitting positions. Some will even lean forward to try to stretch that back even further in that ligament to get pressure off the nerves. So you may see patients trying to lean forward, people trying to lean forward hard to try to get pressure off. And don't really know why they do it. They just know that it feels better. They get numbness. This patient got numbness and tingling in his hip all the way down to his legs and his foot. It just became worse and worse. Stenosis never gets better with time. It only gets worse. So it's a gradual narrowing of the spinal canal where the spine nerves pass through. It can be where the nerves come out of the spine on the side, as you can see on this diagram on the right, or it can be in the center of the canal. If you look at the diagrams on the left and examples of spine, you can see a healthy spine and it's got a spinal canal. You can see that above that big white disc. That's where the disc sits, and just behind it's the canal. Then look at the one on the right. You'll see the redness there. Basically, the spinal canal is all almost obliterated because the ligaments have grown so large in there, it obliterates the canal, and you bet it's pinching those nerves in the back. And it can result in pain, weakness, or numbness. The pain can be relieved by sitting forwards, like as we just mentioned. It kind of pulls the bones apart, pulls the ligament tight, pulls it away, opens the spinal nerves. That's the only way patients can get relief. So before the Vertiflex, you can see that spine that's on top, and after the Vertiflex, that segment where the device is, opened that space just a little bit further. And that's what patients do when they're leaning forward. They're opening those spaces in the back. And that Vertiflex holds it open at the spinal stenosis level to get pressure off the nerves. It is an FDA-approved device. It's only a small incision. The incision's 1 inch. It's the same day procedure, taking only 15 minutes. It doesn't require removal of bone tissue. So we don't anatomically change anything. In theory, it's a totally reversible device. If we want to take it out, and we do, we haven't changed the spine at all. It's still just the same as when we went in there. For speedy recovery time, patients usually don't require any physical therapy to rehabilitate. They heal up and they just start doing their own rehabilitation, if you will. The risk of infection or complications, there's a cited reference right here, and I'm glad to share that with you at the end of the talk. But the infection and complication rate is so very close to zero. It's phenomenal for a surgical procedure of the spine. It can provide long-term relief. We have studies, 5-year studies on patients, and with a significant percentage, well over 50%, upwards of 80% of patients still getting relief even after 5 years. We've done almost 10,000 patients. Well, we did 10,000 patients that have been treated since 2016. This is 2021. I have no idea how many patients have been treated, but you can bet I'm gonna spitball and think it's about 50,000 patients. I could be wrong about that number, but it's a significant amount. And again, we've had unbelievable success with treating this problem. That otherwise, the only other option may be a large surgical decompressive procedure, and we've talked about those too. We do a lot of patients that the surgeons refuse to take care of and do the surgery because they're either too old, too sick, or both to tolerate the anesthetic and the surgery time. Gladly take those patients, and they do very well with this, with less complications. Here's a Bill that had this done. He was talking about how his leg pain, which was killing him before, that's completely gone. We love hearing that. We love hearing somebody that's completely gone, and I've had those patients. Gloria said the day of her procedure, she got out and went to the butterfly park in Scottsdale, walked around without any problems. That was the day of her procedure. Sometimes it's not that good, but it can be that good. It can be instantaneous. Studies have shown that patients are satisfied with the procedure 9 out of 10 in one study. 9 out of 10 patients were satisfied with it. Glad they had it done. 85% had a drop in using opioids. 81% improved their physical function, which meant they could stand longer and walk further and do more activities. 75% said a reduction in pain symptoms in the leg. And that's what it's indicated for. So we see phenomenal results. Spinal cord stimulation is the other more aggressive procedure that's commonly done of the surgical interventions. So the surgical interventions that are implants, it's either going to be pumps, Vertiflex procedures for indirect decompression, or spinal cord stimulators. So who can benefit from a spinal cord stimulator? Traditionally, it's known that spinal cord stimulators work for neuropathic pain and not mechanical pain. So an arthritic knee may not get better with neuromodulation or spinal cord stimulator, but nerve damage after an operation, say around the knee, that cause burning, stinging pain, with just light touch around the knee because of maybe some nerve damage, can respond very well. Most important thing is make the correct diagnosis to see if this is really what the right therapy may be. Common ones are neuropathic pain in the legs and feet, such as diabetic neuropathy, not treated with medication well, failed back surgery syndrome, which in the United States is the #1 indication for implantation of spinal cord stimulators. In fact, I would say estimate at least 80% of stimulators are placed for failed back surgery syndrome. And failed back surgery syndrome just simply means, it didn't mean the surgery was done badly. It didn't do what its effect was supposed to be. It simply means that the surgery was done to make the patient's pain better. And although done well, and our surgeons in our area do it well, it just simply didn't achieve the results we were looking for. So it failed to do that. That's what that means. So have you been treated by a pain specialist for over 6 months? In other words, what they're saying is, have all the more conservative things been done and you're still not better, you may be a candidate for implant therapy. And it treats pain in the back, legs, and feet. There are some procedures that are done for neck and arm pain, thoracic pain. We're using neuromodulation for a variety of different pain syndromes. Most commonly, it's going to be pain in the back, legs, and feet, though. Complex regional pain syndrome, which is CRPS, all formerly called reflex sympathetic dystrophy, is a terrible neuropathic pain condition that affects the arms or legs after some sort of injury occurs, where there's swelling, purplish discoloration, contraction of the skin, loss of hair, shiny skin, and features of extreme pain, extreme dysfunction of the extremity, and even severe pain with light touch, such that even wind blowing on the affected extremity can be excruciatingly painful. It's a very horrible disease and still not well understood. Neuromodulation has been known now to be the most effective therapy for complex regional pain syndrome by far, looking for immediate relief and long-term relief. How about how much pain medication are you taking? Is your current pain level 5 or higher, and it's not getting benefit from pain medication? Have you tried physical therapy, TENS, epidurals, radiofrequency ablations? All of these are the more conservative procedures on the lower tier level, and they're simply not working. So spinal cord stimulator therapy is often considered when all of these options have failed, and the patient may be having neurologic pain or neuropathic pain. And if so, this may be just the right therapy for them. It's been in use for over 40 years. First neuromodulation implant was done by a neurosurgeon named Dr. Sheely at Case Western University in the 1970s. I was in high school, so that's how long this has been around and been developed. So I've been using these since I started in practice in 1989. It's been around a long time, and they have evolved to be far more effective in their ability to relieve pain and how they function over the years. We've really done a lot of research and development work on these things to make them more effective. It's FDA approved, and it has been for all those years. It's a non-drug therapy. It uses neuromodulation with electrical pulses of current across electrodes that contain little contacts, metal contacts on them that go from one contact to the next. You can see an example on the left side of what this looks like with the 2 wire electrodes that have little contacts on them. It may result in a reduction of oral drugs and their side effects. That's one of our main goals in trying to do this. It's covered by most insurance plans, including Medicare and most workers' compensation programs. Medicaid is the only insurance carrier that poorly covers this, and sometimes it can't get done. But we've seen all other payers cover this as a benefit. And the new improvement in technologies have dramatically improved patient outcomes. And I'll be honest with you and tell you that over the years of spinal cord stimulation, the point came about 10 years ago where we became somewhat disillusioned because the results weren't what we expected. There was a revolution in changing the devices and changing a lot of the programming techniques that are programmed into the system in order to to try to treat pain and research for many years. And when we started using these different devices that really were unique and novel to neuromodulation, we saw an extreme increase in the amount of patients that responded well for many years. It was almost a renaissance in us putting in stimulators over the last 5 to 7 years. As with surgery, there's risk of complications. We're putting a device into the spinal cord, or not into the cord itself, but into the spinal canal, and implanting a device under the skin. And although minimally invasive with a really good safety profile, it still is a more aggressive technique. It can have some risk of complications. For that reason, we usually consider it a last line therapy. So how does it work? There's pain signals, as you can see on this model, coming from whatever nerve is involved, say a back surgery patient, that are down low involving those nerves. So the leads that are placed, the IPG is implanted device, the generator, which you see as number 2, that goes under the skin down low. Typically, if we're putting them in the back, it can go anywhere from a higher to lower lumbar area. Your surgeon determines where it may be best implanted so that it doesn't give you a lot of discomfort. It's the spinal cord stimulator device sends impulses of current to the spinal cord, very low current, to mask the pain signals. And what I explain to patient is as the nerves go in from the affected area into the spinal cord, which is up high where number 3 is, it sends these pulses of signals so that it modulates or de-amplifies the signal going from the main nerve coming from the level down at number 1 up to the spinal cord before it takes it to the brain. It somehow modulates that signal going through the system in complex ways to de-amplify the pain. And that's kind of how it works. It can work sometimes at the brain level, but mostly at the spinal cord level. Medications do the same thing too. They affect transmission of pain from one nerve to the next. But again, they can become very ineffective at a certain point. And neuromodulation can pick up the slack and affect the neuromodulation even better in relieving pain signals going to the brain. It uses an external temporary stimulator device that you test with. So this is a drive it before you buy it system. You don't just go ahead and implant one of these things right out of the chute. We can temporarily put these leads in the back, and we typically will do these in office under an X-ray guidance, and they may take me only 5 minutes to put these in with local anesthesia and minimal sedation. So it's minimally invasive. It's just putting these in like any epidural catheter for a woman that is having a baby that gets an epidural to relieve her pain. Same size catheter, same needle, same epidural space. It really is no different. It's just an electrode lead instead of a catheter. So when we talk about who's a candidate, the first thing, of course, to do is to have a discussion with your treating provider, with your pain specialist, about what your options may be, and ask the question, is this an option for me? Patients will oftentimes come to my office and ask me that question, and I will say either yes, no, or it could be, and I'll explain why to them so they'll understand. We do the trial first, which is usually a 7-day trial. Some providers do shorter and longer, but that's almost standard. It's a 7-day trial where we put this lead in, and the wire that comes out of the skin is taped to the back with a power module. It's programmed by the company representatives that are usually helping us with this programming because they do it the best. They do it better than we do. And then we send patients home for 7 days, and we send them about their life to go do whatever they do. And I insist patients to go back to whatever they're doing and see if they can do it, because although pain relief and reduction in medication is important, improved functionality. I can walk further, I can stand longer, I can cook meals now. I can go shopping at the grocery store and make it through the whole store. I couldn't make it 5 minutes before this trial was done. It was remarkable. These are the things that I want to hear, because restoring function is the best predictor of success with these. Without a restoration of function in some possible way, usually the device has failed and you're not a candidate for implant. And your physician determines that in asking you these questions. So that's what we do when we discuss the effectiveness of the trial, looking for those 3 things and deciding together between us, is it right for you, and did you really get the results you were looking for, and is it right to go through this? And so more questions can be asked by patients about that, and this may stimulate a whole lot of questions about that. So the only thing that I can say is that you have to have a discussion with your pain specialist to decide this, if you know if it's going to be right for you. We say that we're looking for a 50% reduction in pain. 50%, in my opinion, is a little bit arbitrary. I want to see a pain reduction. But I want to see, more importantly, can you get back to your daily activities? Can you stand up and cook a meal without having to sit down every 5 minutes? Can you go shopping at the grocery store, whereas you gave that duty over to your husband and wife because you couldn't do it anymore? Can you go do it now? That really impacts life. Is your need for medication reduced? We try to get people off medication if we can, using this to control their pain. Some patients tell me that during the day they still had some pain and it was okay, pain relief, but they slept at night. Some patients that I put this in slept 1 or 2 hours a night. The pain kept them awake all night. Whole week during the trial, they slept for 6 hours. That gives you restorative sleep. That's an improvement in function and in life. So I'll implant those patients simply because of that. So that's an important question to ask as well, to see if it really did effectively help your sleep, if it's really affected. Some types of stimulators can be personalized for you. They're so advanced now that the type of stimulation you can get, even at your spinal cord level, can be modulated to be one type at a certain level of your spinal cord level, a different type just below that, a different type below that. It can stimulate different and focus on different areas inside the spinal cord to try to modulate pain in different pathways. It's really complicated now. And because we can modify it in that way, it can be much more effective. And we've seen that, as I said before, with the renaissance in putting these things in, because we can start doing more direct targeted of stimulation, we've seen a much higher success rate for a much longer period of time with stimulators. There's paresthesia-induced stimulation, which means you feel a tingling. There's paresthesia-free, in which the modulation is altered so you feel nothing, or you can have combined. We modify this to whatever the patient likes. Some people like to feel the paresthesia, the tingling, if you will, in the back and legs. They like that sensation. They prefer it. We can program that. Some people say they don't like that. They want it to feel nothing, just have the thing on, but not feel anything. We can program that. Some like to go back and forth. We can program that. So we can tailor it just to what patients need now in many ways, including that. Is it safe and effective? In one trial, as you can see over in this graphic display on the other side, there were certain patients that were studied, and I can give you this reference too about this one study, but their pain scores were 8.6 out of 10 on the average in that study population. That was pre-spinal cord stimulator. After 2 years of spinal cord stimulator, their pain reduction was down to almost 3. And it lasted up to 2 years in which we were studying. So the first group of patients was 49 patients studied. At the end of 2 years, 38 were still left in the study, which is a significant amount, and their pain level was markedly reduced. So you know, we've had more than one study that's shown fantastic outcomes like this over and over again. Here's the study you can see that they referenced over here, 2017 study. What's next? Talk to your physician about treatment options. Get a referral to a physician and talk about treatment options. We accept patients without a referral. Most insurances will cover that. And some patients just want to get information because they don't know that they're really getting the best therapies. And some physicians, primary care physicians especially, don't really know all the things that we can do. It's advanced and it's changing so fast. So it's good to sit down and talk to your primary doctor, or even ask for an appointment to come in and see one of us to see if we can talk to you about your problem and assess it and tell you what we may be able to do. Here's a website you can go to. It's simple. It's pain.com, and you can get more information from going to this website, and it can direct you to more places for more information to try to get you informed. There is a million sites you can go to that are directed, but this is a good place to start to try to get more information. So I rushed through that, and that's the end of my discussion, but I think we're going to have some time for some questions now that I'd be glad to answer. Is that right, Lynn?
Absolutely. Thank you very much. We are going to have time for questions. If you have any questions for Dr. Lewis based on anything he presented, you can use the question and answer function or the chat function, and I'll be happy to read those out and we'll answer them. If not, you all have my email, and you'll receive an email after the presentation with my phone number and email address on it. You are more than welcome to email those questions to me as well, and I will make sure that we get them answered. So do we have any questions out there?
Remember, there's no dumb question, only dumb doctors. There's no dumb question. So if you got one, ask it. That's a joke.
We also have a patient on the line as well that is going to speak about her experiences. So I have a couple of hands raised. Let's see, I'm going to, Charles, I'm going to allow you to talk. Are you there?
Charles, are you there? Can you hear us?
If you can unmute, Charles.
Charles, I see your question here and I can answer that for you. Is spinal cord stimulator effective for neuropathy? Answer, yes. In fact, it works for any neuropathic pain for which neuropathies can cause that. Not all neuropathies cause pain, but some do. And so by definition, it works exclusively for neuropathies, not mechanical pain problems. As we talked about before, there's mechanical pain, neuropathic pain, and it doesn't matter what the neuropathy is. In general terms, if you have a neuropathy, and the most common ones I see that are referred to me for treatment are called idiopathic neuropathies. Idiopathic means we don't know what caused it, because others seem to be treated with medication. When you failed medication therapy, all you think you have for treatment of neuropathy is medication therapy. If it's just a peripheral neuropathy like diabetes, medication therapy, or neuromodulation. You only have two choices. So Charles said back, I hear but I don't have a microphone. Type me again another question. I'd be glad to answer for you.
We also have a question. Tell us about the MILD procedure.
I'll be glad to. And I do the MILD procedure as well. MILD is an acronym for minimally invasive lumbar decompression. And that's really a acronym that's coined by the company that makes it. And so basically what that is it is a decompressive operation in which tissue is removed. So under fluoroscopic guidance with what we call an epidurogram, injecting dye in the spine, we adjust a fluoroscopic unit to try to see where the defect is, where the enlarged ligament is, and then through a small incision in the back, which is really just a little puncture hole, we insert an instrument at an angle through the lamina, which is the two bones that we try to put the thing in between. And really, we just try to snip and remove a lot of that tissue if we can, or at least a significant amount of the tissue with direct visualization. It's not with indirect visualization with the fluoroscope, not direct, well, it's an open procedure. So it is a surgical decompressive procedure that is removing tissue, but it doesn't require an incision. It doesn't require removing any bone. It really doesn't even require a stitch to be put in. It's an ambulatory procedure, and it can be done very, very quickly, even with the same local anesthesia with sedation. And so which one of those may be right for you for your stenosis? Talk to your doctor that does both, and he can tell you which one he thinks would be right for you. It may carry a little higher risk, but only slightly higher. The risk profile of that is still extremely low, and complications have been extremely low with the MILD procedure. Problem we've had is insurance reimbursement, but that's about the worst problem you run into, to see if insurance companies will cover it.
Thank you. We have another question from Sherry Wilson. I had my nerves burnt on both sides. It's been a few months. I need it repeated. What do I do?
So you can ask your doctor that did that and get another appointment. But in general terms, that's limited by insurance benefits. And so let's say, for instance, Medicare is very strict. And they'll say if you get these nerves burnt, and I'm assuming it's basically the medial branches that are going to the facets. That's typically what we're talking about. So that's what we're talking about. Medicare allows that to be done only every 6 months, and only if the first burning procedure has been effective. And they're changing their stipulations on that too. So it must be the block that has to be done before it must be 80% effective in relieving your pain. And the rhizotomy procedure must be 60%. I think it's 60% effective, which is, I don't understand why it can be less effective than the block. And you can repeat the procedure, but that's Medicare's rules. So most other insurance companies have the same 6-month rule. If you have a different carrier, say Workman's Comp, or it's maybe a Veterans Administration or something, they may not have that rule. But your physician needs to answer that question for you specifically, knowing what your insurance is and how did you respond to the first one.
All right. Any other questions?
Anonymous attendee, Dr. Roz did my one with the radio frequency. That's Dr. Roslansky, I suppose you're mentioning. And So awesome. I think Dr. Roz is an excellent doctor and he does a good job with this. Hopefully you've got a good response. If your pain comes back, then you need to follow up with Dr. Roz and look at options. There are some patients that'll come see me at 5 months and say, Dr. Lewis, the rhizotomy worked great for 5 months. Now the pain's back and it's killing me. What can you do? What can you do? Well, we have to figure something out and wait till the 6th month and 1 day so we can be under the wire to do it with Medicare to get it covered as a benefit. So maybe a facet injection with steroids, which may be less effective, but it may buy you a month in order to get there, can be done, and Medicare will approve that typically. So we try to figure something else to try to get you to that 6-month benchmark, and so that we can get it done and covered by Medicare. But just come on in and ask, and we'll find something.
There was another question. Is there a procedure whereby the nerve is moved?
Is there where the nerve is moved? The only one I can't think. If you can give me more information about that, I can tell you about what I think. Most of the procedures that we do, either blocking a nerve or lesioning the nerve, putting steroids on a nerve, we don't really try to move nerves. That's a surgical procedure to try to move nerves out of the way. So it depends on the problem, but if you're more specific about what the condition is, I can answer that.
All right. So if there's, and then the other one, what are some procedures for herniated discs?
Let me answer Mr. Roper's question here. I had a follow-up question, and I'll answer that one.
Got it.
I didn't say Medicare actually is a great cover, gives great coverage to spinal cord stimulation. It was Medicaid. If I've said it wrong, I apologize. It's Medicaid that doesn't cover it very well. And that's in every state. Medicare covers it, no problem. AARP and United cover this benefit. We have to get it prior authorized, and usually we can do it if it's really indicated. But there's only Medicaid is the carrier that we have a problem with. So the question about disc problems was, what was the question again?
What are some procedures for a herniated disc?
It depends on what the problem is. If it's a contained herniated disc not pressing on a nerve, most surgeons will not operate on that. What surgeons are really looking for is something that's compressing a nerve, causing pain, numbness, or weakness in the distribution of that nerve, so they can go in and get pressure off that nerve. That's number one. Number two is they go in for instability. So if the spine's unstable, they go fuse it to create stability. Those are what the things they're looking for. So if you don't have loss of function with your herniated disc and just pain, conservative measures can be done. So in our practice, we see what the problem is, see what the disc is, and the first line therapy is an epidural steroid injection. If you get benefit from that, we can repeat it again in 6 months. There's some discussion about series of 3 epidurals, which were done back when I was in training, but we never did fluoroscopically guided, injections. We did blind injections, which we were good at, but no data to support how well they did and how to follow it up. We just didn't study it. We don't do that anymore. We do an injection now and take a look and see how you respond. If you don't, we may not repeat it. If you do, we may repeat it, but we won't go over 3 in a series 2 to 4 weeks apart with each injections. You can repeat that and almost indefinitely, but realize the more steroids you get, the more exposure to steroids, the more complications you may get. And although not life-threatening, they're not great. You can also get a percutaneous discectomy. We do that in our practice, where a needle is placed under fluoroscopic guidance into the disc itself, and then a device is put in there to either coablate the nuclear material or remove some of the nuclear material with a little forceps, trying to decompress the disc itself and shrink that herniation to pull it back away from the nerve without having to do an open procedure. And it can be very effective. If it doesn't work, you can always have an open procedure to do it. But usually after an open procedure's failed, you can't go back and have a more conservative procedure. So those are the 2 mainstay therapies that are not surgical, like open surgical procedures, but can be done conservatively to try to help herniated discs, depending on what the pain condition is. So let's see.
You also had another one. I had a recent fusion and it helped, but pain is moving to other areas of my back and almost no leg pain. Would a stem possibly help?
Yes, and so, like I said before, the most common indication or diagnosis used for placing a spinal cord stimulator in the United States is failed back surgery syndrome. That's a type of failed back surgery syndrome. So you don't know, and so in back surgery procedures with back pain and leg pain, or back pain without leg pain, is it purely mechanical, purely neuropathic, or both? So it can be neuropathic regardless of where your pain problem is. Well, how do you decide? Well, if we failed all other therapies, you failed physical therapy, you failed facet blocks and rhizotomies, if you have only back pain, you failed steroid shots, whatever, and medication's not cutting it, we go ahead and do a trial. And we look for the three things: pain improvement, reduction of medicine, and improved function. If we see those things, especially improved function, we implant. So yes, I would consider a patient that had just back pain after fusion, exhausting all of their measures, no further surgeries indicated, and trying the spinal cord stimulator, see if it would be effective. But I'm pretty stingy about implants. I'm generous about doing trials, but if it comes to an implant, I want to see you respond before I go for it. I want to keep my success rate high and my reputation good. Let's see, Dr. Ross did the RF, so what should my next step be if that doesn't help? My answer, of course, is if a physician's done some procedure, Dr. Ross or anything else, and you're still having some pain problems, go back and see Dr. Ross and ask him what your next step is going to be, because he's a smart doctor and he knows other techniques to do. You may ask, is a spinal cord stimulator right for me? Do I have stenosis and maybe a vertiflex is for me? You'd have to look at your MRI and make that decision. So I would return to Dr. Ross and say, hey, I saw Dr. Lewis's presentation and he said, I should come back to you and ask me what my next step is because that rhizotomy didn't help.
We got a little more information on the moving the nerve. It said it's from a slipped disc pinching the nerve.
So you really, it's not a matter of moving the nerve away from the disc, but moving the disc away from a nerve, because that's what's occupying the space that shouldn't be doing it. So surgeons won't go in there and say, well, I'm going to get the nerve out of the way. That's pretty difficult to do. There's not a lot of room. They're going to try to remove the disc material, or they're going to try to remove the ligament that may be enlarged pressing on the nerve, and not necessarily try to move the nerve itself. That's not going to be effective because you still got the same herniated disc there, and the nerve may move back and still get compressed. So in general terms, I would say it's move the disc, not move the nerve.
And then I have another one, is Floanex pump used to inject opioids?
Flowonix is another company. There's two companies out there, Medtronics and Flowonix. Medtronics is the oldest, and they've been around, oh gosh, for longer than I've been in practice. My first pump I put in was in 1987, 88 with a Medtronics pump. Flowonix came around about 10 years ago. And it was a bunch of people that left Medtronics and developed their own pump. It's effective. It can get the job done. They look almost the same. The only difference is that their mechanism for how they infuse is a little bit different. And they have their own special issues that need to be understood before putting one in, and cautions about especially getting MRIs with the implanted pump, which if this is being considered by your physician, you need to ask him, what are the issues surrounding this pump compared to the Medtronics? Why would you put this pump instead of that pump? Why would you put that pump instead of this pump? Those are the right questions to ask, and your physician can answer those questions. But they're both effective, both FDA approved, and both, when used correctly, can be very safe and effective.
Awesome. Well, we're going to take a little break from questions. I do have a patient on the line, Kira, who actually has a spinal cord stimulator. She's had it for a while, so she's going to talk about her pain journey and her experience with the spinal cord stimulator. And then at the end, you're welcome to ask more questions to either one of them. So Kira, I will pass it along to you.
Hello, and thank you guys for hopping on tonight. I am Kira. Full disclosure, I'm actually one of the clinical specialists for Boston Scientific. I've been with the company for 12 years, but I've been implanted with a spinal cord stimulator now for almost 11 years. A little bit of background. My background is in pain management. I was a nurse in a pain clinic for about 6 years before Boston Scientific hired me over. And again, I've been with the company for almost 12. So I've spent most of my career in the pain management field, in one, space or another. Kind of what started my whole pain journey was I was actually reprogramming a patient. It was right after Christmas. It was the first part of January of that year, right after Christmas. And I stood up off of a stool and I felt kind of like a weird twinge in the top of my right thigh. And I didn't think a whole lot of it because I had just come off of a dinner theater program. And we had just taken a trip to Fayetteville, so I didn't really think a whole lot about it. But as the day went on, this heat just kind of built in the top of my leg, and it started to build, and then it started to spread up through the thigh, up the side of my hip, and then all the way across the right side of my lower back, to the point of when I got home that evening, I couldn't even stand to hardly have a pair of pants, touch that leg. And I looked at my husband and I was like, we've got to do something. Like, something is very, very wrong. So we dumped my daughter, who was 2 at the time. We dumped her with my parents and head to urgent care. There wasn't a whole lot they could do there. So they sent me to the ER, and there was really nothing that they could do. They took x-rays, they looked at my hip, they ran an MRI. There was no problems, but I just had this horrible, excruciating pain in my hip, in my thigh, that the burning just kept getting worse and worse and worse. They handed me a prescription for 60 Percocet. I had a $500 copay, and they sent me home with instructions of, if the pain doesn't go away in 2 days, to follow up with an orthopedic surgeon. Thankfully, having the background that I do, I picked the phone up the next morning and called one of the doctors I used to work for and was like, look, this is what I'm dealing with. What can we do? I am so uncomfortable. I can't concentrate. I can't sleep. I kind of was in that space where I kind of slowly started to feel myself start to go a little bit crazy. We didn't really know what was going on. He brought me into the clinic, and I had my first ever nerve root block with him, not really knowing, what we were really getting ourselves into. 2 days later, I woke up and I had this horrible rash that had broken out all across my thigh, up the side, and across the back, tracing that pain pattern perfectly. It took 4 days, but I finally lesioned, and I actually had a very, very aggressive case of shingles. I was 28 years old. I couldn't hardly walk. I couldn't hardly stand. I couldn't hardly work. It was terrible. So we were leading into February at this time. And from February to, I'm going to say, almost May of that year, I had a series of 6 injections, none of which really did a whole lot. I would say generously that they maybe just kind of like carved the edge off of the pain to the point where I could work. Even then, though, the working really wasn't very easy. There were times if I had to sit in the car for long periods of time, I would actually pull over to the side of the road and get sick on my stomach. I would throw up because the pain was so bad. Sprinkled in there, I was working with one of the neurologists in the Charlotte area, and he had me on different cocktails of neuroleptics, trying to get any type of semblance of pain control. I was on a couple, like 1 dose in the morning of one medication, another dose at night of another neuroleptic. We were treating it just as aggressively as we possibly could. That was, within some realm of safety. I told them, I just want to feel better. I don't care how we go about doing it. As we kind of led into June, I was a wreck. The medications, I was having horrible side effects with the medications. I was having tremors. I was having memory loss. All I did was, I wanted to sleep, but I couldn't sleep. And I truly at that point felt like my handle on life was just slipping away. My daughter was 3 now at this time. She didn't understand why mom couldn't play. She didn't understand why mom was in the bed all the time. She didn't understand any of that. She was 3 years old. And I sat down and had a very difficult conversation with a physician who I considered one of my best friends. And he said, the only other thing that we could try was spinal cord stimulation, or we could try, at the time, there was this like a patch out for post-herpetic neuralgia, which eventually that's what I was diagnosed with. And I said, there is no way in this world I'm having a spinal cord stimulator. It's not going to happen. I had a birthday by then. I was 29 years old. I was like, I am not ready to go down that path. We are going to do the patches. We're going to try that. And he was like, okay. So we did one more epidural or nerve root block. I can't remember which one. And he sent me on my way to start the process of getting that other thing done. Something I always tell the patients that I work with, and something that I experienced myself, is there's always a tipping point for a patient when it comes to having anything done. Whether it's something as simple as an epidural injection or something like a spinal cord stimulator trial or whatever that you're trying, and thinking about getting done. Every patient has a tipping point where they're like, okay, I'm ready. And if you try that, whatever it is, that procedure, before that patient gets to that tipping point, I firmly in my heart believe that the results aren't going to be as good. And for me, my tipping point with the spinal cord stimulator came about 3 weeks after that last injection. I came out of a doctor's office from seeing a patient, and I got in my car, and I remember thinking, gosh, I'm hungry. And I cranked the car and I looked at the clock, and it was a little before noon. And the next thing I remember, it was about 3:30, 3:40 in the afternoon. And I was still sitting in my car. It was still cranked. And I was still in that same parking spot. And I got so scared because I was thinking, did I pass out? Did I have a seizure? Did I black out? What if I would have been driving? What if my kid would have been in the car? What if I would have supposed to have been at a surgery? It was all the side effects from the medication just caught up with me that day. And so I made the phone call to the doctor and I said, I don't know where we are in the process, but I'm ready to have a trial. I want to do it like ASAP. And he said, okay. And so about 3 weeks after that, I had jumped through all of the insurance hoops. The approval came through, and it was finally the time for me to have my trial. And I was so nervous. I don't really know what I was so nervous about because I had already been through essentially the same procedure. Like Dr. Lewis mentioned, it's done through a needle, just like your epidurals, basically, only instead of putting the medicine in, they're threading those little catheters in. But I was with some of my good friends, I'd worked with these ladies before at the office that I was in, and I just remember thinking, I cannot believe I'm doing this, but this is literally, this is my last hope. If this doesn't work, I have no idea what I'm going to do. And so I laid on the table, the numbing medicine went in, the little epidural needle went in, the catheters went up super easy. I didn't really feel a whole lot. There was a little scratching, nothing uncomfortable at all. And when the stimulator came on for them to test, and this is something you'll experience too if you guys decide to move forward with a trial, I remember finally feeling that fire that had been in my leg and in my hip. It started to kind of cool off. And I just remember thinking, holy cow, the fire is gone. What we did is we blanketed like the right side of the back through the hip and all across the top of my right leg. This stimulation, when it came on, it kind of squelched that fire as it built and kind of spread out. For me, that's what it felt like. If you can put 15 stimulator patients in a room and they're going to give you 15 different answers about what it feels like. And that's okay. That's just their brain and my brain's way of interpreting what's going on. But we got the coverage that we needed. I went home just for a long weekend because your trial will probably be longer than mine. Mine was only a couple of days just because of our work schedule. But I remember that weekend I went home and I slept, which was amazing. I was able to go out into the yard and play with my daughter. I was able to go do something as simple as being able to go out into the grocery store and be able to put on a pair of pants without feeling like someone's peeling the flesh off the side of my leg. It was a wonderful weekend, and I finally was like, there's a tiny glimmer of hope that I'm going to be able to get my handle back on my life. After that weekend, I went to the office, the little trial catheters came out, we documented everything for insurance purposes. And a couple weeks later, my implant was done. That was, like I said, almost 12 years ago. And it is hands down the best decision that I've ever made. I can work, which is, people ask me, they're like, would you be able to work without this? No. I can tell you with absolute certainty that if I didn't have my stimulator, there's absolutely no way I could go to work. I tell people, if you turn my stimulator off and come back in the room, 2 minutes later, you're going to see a very, very different person, because my pain, even all these years later, if you turn it off within a minute or two, my hands start sweating. I start getting very anxious. The pain is still very real. The pain is there if I turn my stimulator off. If I leave it on, I'm not going to say I'm pain free, but my pain is definitely at a tolerable level where I can do what I want. I can go to my yoga classes. I can work. I can play with my kids. I can fold laundry. I can cook dinner at the end of the day after working all day. I can go on a walk. I can go on a bike ride. I can do these things that 12 years ago, there is absolutely no way that I could have done at all. For me, looking back on this, if a doctor offers you a trial, odds are they already think that you're going to be a good candidate. They're not just going to willy-nilly hand out DVDs. I tell them, you have nothing to lose but roughly 5 days of not being able to shower and potentially a whole lot of pain. And you're going to gain a better quality of life. You're going to gain being able to sleep, to walk around, to spend time with your family, to plug back into the things that you want to do. It's the best decision I've ever made. And I am more than happy at this point. I know we're going to open things back up for questions. I'm more than, happy to hang out and answer any questions that you guys have about the trial procedure, about the implant procedure, about any type of programming, like what type of programs I use or anything like that. So I'm going to turn this back over to Dr. Lewis and Leanne and let you guys take it from here.
That's such a great story. And I'm sitting here thinking about a patient. I'm just going to spend 30 seconds. I just got to Asheville and I had this patient. She's about 35-year-old. She had factor V Leiden deficiency, which is a hyperclotting disorder. And she kept having blood clots that would go to her lungs, which were pulmonary emboli. This is what they have. It's a genetic disorder. They can't help it. And it kept going. And it's painful when you get a pulmonary embolus to the lungs and you go to the hospital and they have to admit you, and it's life-threatening. It can be. So for about a 12 or 18-month period, this patient had been through about 9 or 10 emergency room visits or hospitalizations for increasing chest wall pain, and it never would go away. And they couldn't find that she had a clot. And so the conclusion of the physicians was, this is a drug addict seeking drugs. That's the only answer to this problem. Because there's nothing wrong with her. She's not having blood clots. They didn't look at the patient. So somehow I got called and I went to the hospital, looked at her. And her chest wall, where she usually had her pain, she was like severely allodynic. Allodynia is light touch causing excruciating pain. That can happen in postherpetic neuralgia. It probably happened to you too.
Oh, 100%.
So that's just a key that, no, you're not working with the pulmonary embolus. You're not working with a drug addict. You've got complex regional pain syndrome of the chest. No one was sophisticated enough to make the diagnosis. So I said, we got to do a stimulator. And it was a old stimulator, that we put basically in on that side of the chest. I had her on the table and I put the stimulator in, I put the needle in, advanced stimulator. She's in terrible pain this whole time, but really tough and tolerating it. And we tested it. So we turned it on the table and she started crying. And I thought, oh God, I've hurt her. I paralyzed her. I said, what's wrong? What's wrong? And all she could do was just cry and say, my pain stopped. Mm-hmm. And it had been going on for 2 years and it stopped. And finally, everybody was a believer at that point for this poor lady. So we implanted her and I lost her to follow-up. She just went away living her life. So I love great stories like that. And I have some with neuromodulation.
Well, are there any other questions out there? Thank you both so much. Thank you, Kira, for your story. Let's see, we got not a question, but I'm very glad you offered this. She agrees with you that Roz is awesome. And had no idea that is why I could sleep not more than a couple of hours, or why at times I look people in pictures. Not a question, but I wanted to let you know. She's at the Marion office. So that's wonderful. Thank you. Thank you for coming.
Yeah, thanks, everybody. I appreciate the opportunity to talk to everybody. Please contact us if you have any more questions. Happy to answer.
Most definitely. Before we go, I've got a quick little poll, if you wouldn't mind filling out, just telling us how you've heard about this event. And then also, if there is anything that you want more information on tonight that we discussed, you can click that as well. And then I will get back in touch with you with the information that you wish. You'll also get an email from me after this event. It will have my phone number on it and my email address. If you have any questions, want more information about anything that was discussed, please let me know, and I will be more than happy to get that information to you as well. But thank you all for coming tonight. Dr. Lewis, thank you for presenting. Kira,
Pleasure.
thank you for sharing your story as well. And I hope that it has helped a lot of people out there.
Have a good evening, everyone. Thank you.
Thank you.